Good afternoon, Dr. Voltaggio. Thanks for taking your time and travel all the way from Baltimore to be with us.
Thank you for having me.
Dr. Voltaggio is a GI pathologist at Mount Sinai. Sorry,
Right now, I'm at Mount Sinai. Dr. Ruben, if he's watching, it's okay. You don't have to worry about it.
So it's all yours. So she's going to present the slide seminar on colitis, a pattern-based approach. So that's how she wants to discuss the slide.
You haven't said where she is from.
Hopkins.
She's from Hopkins.
I'm right now at Hopkins. Been there for 3 years. So thank you everyone for coming, and thank you everyone for joining us wherever you are. So we'll start right away with the first case. Kunwar, do you want to read it?
Sure.
The extensive history that I provided.
20-year-old male with bloody diarrhea and abdominal pain for 2 months.
All right. But first, we'll start with normal. And I know everybody here is familiar with normal colonic histology, but I know we have a couple of, first or second year residents, so we're going to go through it. And this is what I like to say when I talk to my residents and fellows about normal. And what I like to see are these colonic glands. Do we have an arrow?
Oh, yes. It should.
And the mouse will go through.
Is he not coming up?
No.
There you go.
You have to turn it on.
Yeah.
No, it's not coming up.
Yeah, it is.
It is.
It's
Just,
flash.
yeah, here you go. Just lighter, the red one.
Yeah.
There.
Oh, I don't see it. It's okay.
The mouse will work.
I'll do the mouse.
Yeah.
Okay. So basically, I like to see my colonic crypts nice and straight coming from the surface, trying to kiss that muscularis mucosa underneath. In between the crypts and the muscularis mucosa, I don't want to see any lymphocytes, plasma cells, eosinophils. You can have, one or two, that's okay, but typically no basal lymphoplasmacytosis. The other thing I like to point out is the amount of lamina propria in between the crypts is the same as you move from one crypt to another. So the crypts stand equidistant one from another. And remember the differences between the cecum, or the right colon, and the left colon. This is a biopsy from the sigmoid and shows a lamina propria pretty devoid of. You see a couple of inflammatory cells here and there, but not really a lot in the way of lymphocytes, plasma cells, and actually EOs are rare. But when you get biopsies, and I'm sorry I didn't bring one from that was on the left. If you have something from the right, your lamina propria is typically busier, and I allow for quite a few eosinophils, lymphocytes, and plasma cells. The other thing that you want to keep in mind is let me just go back to the H&E for a second. The basement membrane. I will be talking about the basement membrane a little bit more, but on the H&E, you can see that it's a nice straight line. Oh, there's my arrow. A nice straight line underneath the surface epithelium that is not entrapping any capillaries or inflammatory cells. So it's nice and smooth and straight. And to illustrate that, you can order a trichrome stain if you're on with a first-year resident and show that very nicely on your trichrome. So here's your very flat, smooth collagen table underneath the surface colonic epithelium. All right, so let's go ahead and get to the first case. So bloody diarrhea. And first of all, what I like to do at low power is comment on the chronicity, the degree of architectural distortion. And Samer, what would you say about the architecture at low power? And it's typically a bird's eye view. And just tell me what you think. If you're right, you're right. If you're wrong, you're wrong. And that's fine.
It looks hypercellular.
Yes.
There's less crypts than the normal.
Yeah, so you think there's some crypt dropout.
Yeah.
I think you're right. What else? What would you say about the glands themselves?
They look elongated, maybe angulated.
I would say they're a little bit shortened. So compared to the normal case that I showed before, here's the muscularis mucosa, and here's the bottom of your gland, and there's a lot of space in between the muscularis mucosa and the bottom of the gland and the crypt. So there's that, we would call that crypt shortening. And if you look closely, you'll see some basal lymphoplasmacytosis that includes some eosinophils. So the other trick I like to use, and I heard this from Dr. Appelman one time when he was lecturing, and he described crypt architecture in cases with inflammatory bowel disease. You no longer have that nice, organized test tubes in a rack kind of architecture. The glands start to look like anything they want to look like. Rabbits, monkeys, the face of Jesus, whatever, and except for test tubes on a rack. And the other thing is sometimes you'll see them, instead of growing down, they'll grow sideways. So that's very aberrant, very abnormal. So I would say this is great evidence of chronicity, good architectural distortion. What other features besides architecture can you see in cases where there's some chronicity, albeit non-specific findings? I mean, nothing is specific in chronic inflammatory, colonic pathology. But what other features would you expect to see in patients with inflammatory bowel disease? I don't remember. I think this is a biopsy from the right colon. So if we see it here, it doesn't matter. But in cases from the left colon, what's a good finding that indicates chronicity? Yes, Paneth cell metaplasia. Is it specific? No. Can you see it in like drugs and other like collagenous colitis, other types of inflammatory processes? Yes. So the other finding would be pylori gland metaplasia, which I find a little bit more difficult to spot if you're not really looking for it, because the glands kind of blend in to the background colonic mucosa. But once you learn to look for it, you'll find, and we'll see a little bit of it further down the road. So this is a case of inflammatory bowel disease, and this is what I like to compare everything to in order to avoid labeling patients with IBD who don't have IBD and who should be receiving other treatments other than immune suppression. So just have this, this level of architectural distortion in your mind. Let's look at a couple of cases in the differential diagnosis. So this is a patient with a history of pancreatic cancer. That's all we get. So Wei, what would you say about the architecture in this case?
This is left colon or right?
This is left colon.
Okay.
I think this is rectum. I think so.
I definitely think there's a distortion.
There's a little bit of distortion. I would give you that. But overall, the glands are trying to keep their distance. They're equally distant one from another, and they're trying to keep their shapes overall. I wouldn't say the architecture is perfect, but overall, they're trying to retain it. And you mentioned whether this was from the right or left, and I mean that's a good question. I would say since this is from the rectum, the lamina propria is actually expanded, so I would say it's too cellular for rectum. So I think IBD would be definitely in the differential with that degree of architectural distortion, maybe, but with that degree of inflammatory lamina propria expansion. But let's look a little bit closer and look at the cytology. So one thing we note is these dilated glands with flattened, morphology, flattened epithelium, lining the glands. And what else? There's a couple of ugly-looking cells here with prominent nucleoli that are looking right back at you. They almost look like melanoma nucleoli. Oh, there might be. I wouldn't be surprised.
Across the way, across the hall.
Let's see. I'm missing it.
No, never mind.
Okay. I think what's catching my eye for the most part is the prominent nucleoli. But what would you say about the NC ratio?
For most cells, I think it's preserved, but that big one is maybe slightly increased.
Yeah, I think overall it's low. You had loads of cytoplasm. Even though the nuclei are big, you have loads of cytoplasm. So with this morphology, first of all, so the question was, inflammatory bowel disease. Okay, maybe, but the cytology is not great for it. The degree of reactive epithelial changes, although you can have some crazy looking inflammatory bowel disease cases, is really crazy. And when I see crazy, bizarre epithelial atypia, I think about treatment effect, either chemotherapy or radiation. Both of them can give you this crazy cytologic atypia that sometimes may actually make you think of cancer. We've got a couple of cases received in consultation, I'm remembering one specifically in the stomach where the question is, what about this cancer? And it wasn't. It was just crazy reactive epithelial changes in a patient who we didn't know, but the patient had received radiotherapy for lung cancer. And it definitely looked a lot like malignancy, but there was something not right about it. So this patient was receiving at the same time chemotherapy for his pancreatic cancer. One thing you can see in patients, especially when they're receiving radiation, is a lot of eosinophils and even intracryptal eosinophilic microabscesses. You don't see a lot in the way of neutrophils. You may see some neutrophils in the cytoplasm of the nuclei, like intracellular intracytoplasmic neutrophils, but not really neutrophilic microabscesses. And the other thing you might see is intracytoplasmic vacuoles, degenerating vacuoles. So this is a good example of chemotherapy-associated colitis, a mimic of inflammatory bowel disease. Oh, this is a good one.
But without the chemotherapy, like a lot of them we don't have a history,
Mm-hmm.
and it still doesn't have. You just describe what it is.
With that degree of the mild degree of architectural distortion is what's making me fall short of saying this is for sure IBD.
Yes.
So I would be descriptive, and I would say, active colitis or focally active colitis with marked lymphoplasmacytic, whatever lamina propria expansion and marked reactive changes, and give a differential. And with that degree of nuclear to cytoplasmic ratio, the low NC ratio, I would raise the possibility of treatment effect. Could it be, emerging IBD? Sure. The cytology is not right for it. But in the absence of a clinical history, it's tough. It's really tough, especially when the clinician takes the biopsy and tells you, is this IBD? It looked like IBD. So, yeah.
Because most of the time we get to, almost like there's no history.
Yeah.
Like the one that's.
Descriptive is fine. Descriptive is fine with the differential. Yeah. So this patient has a history of diarrhea. Sean, what would you say about the architecture here?
It seems like in certain areas the cliffs are inconsistent.
Yeah. It's mostly preserved. Some areas you might want to argue, well, there's a little bit of crypt dropout here and there. I'll give you that. Maybe here, sure. But the overall pattern is preserved architecture. So when I see that, okay, IBD is not my first in my differential. Are there cases of IBD where architecture is preserved? Yes. When? Pediatric patients, when they present, can have perfect architecture. Well-controlled patients can have good architecture as well. So nothing in inflammatory bowel diseases, can be dogmatic, but that's the general rule. So we've established the architecture is pretty much preserved. So what about the inflammatory components?
So yeah, it looks pretty hypercellular.
Yeah.
And it's okay, but there's a lot of plastic cells.
Okay, and there was some area here. Let me see if I dotted it. There were some areas where there was good active inflammation with even some cryptitis and maybe one or two crypt abscesses. Of course, now that I want to find it, I can't. Hold on. But believe me, there were. So when you see this pattern, so active inflammation, minimal architectural distortion, the patient has diarrhea that has been, short-lived, not really like chronic diarrhea. What would you think about? So, here we have a good cryptitis and good abscess. And here, the other thing to note is that the inflammation tends to be superficial. So infectious bacterial foodborne colitis, that would be my main differential. And this patient had proven Campylobacter Colitis, which is, you get it from eating predominantly contaminated poultry, but you can get it from a variety of sources. So this is what infectious bacterial, what used to be called seb-limiting colitis should look like. So nice architectural distortion, active inflammation, maybe some crypt abscesses, and the patients have a history of diarrhea that is, short-lived, not like a history of like months and months of diarrhea.
Do you know the term self-limited that I was talking no longer used to?
No, people use it. I usually don't use it. I'm descriptive and I just say, bacterial, infectious. There's nothing wrong with using it. Yeah, there's nothing wrong with using it. Oh, this is another good pitfall. So this one I dotted. Let me see if I can. So I included this because this case has a very abnormal, thick, irregular collagen table. And when I got it, I didn't really know the patient's history. So I was thinking this was collagenous colitis. The thing is, some areas, the architecture was sort of preserved, but then in other areas, we had a good degree of gland dropout. And look at this fragment right here. I mean, that fragment shows good chronicity. And then fragments like this had tons of eosinophils, which really is not neither here nor there, because patients with IBD can have tons of EOs. Patients with collagenous colitis can have tons of EOs. So we go to the chart just because the case smell kind of funny, and the patient has long-standing IBD. So it turns out the patients with long-standing IBD can have this thick, aberrant, irregular collagen table that sometimes can mimic collagenous colitis. And there's a couple of other mimics of collagenous colitis that we'll discuss further down the road. And then the last differential is this. All right, so Emilio, what would you say about the architecture in this case?
Well, it's predominantly preserved, but
Yeah, but
well, the laminar propria is very
yeah, and then in some areas there's a little bit of distortion, but what's the distortion associated with? Yeah, a huge lymphoid aggregate. So this case, as you move along, you'll see a couple of prominent lymphoid aggregates. There, here, in the backdrop of preserved lamina propria. So then, okay, it might be IBD, especially because there's pannate cell metaplasia, and this is from the rectum. You see the pannate cell metaplasia is showing well? Yes. But what they're not telling you is that this is from a Hartmann's pouch. So the patients had colostomy. And the patient had a surgery for diverticulitis, and they couldn't connect them right away. So the patient developed diversion colitis. And diversion colitis can have good chronicity, can have good inflammation. And I've seen cases that really look like inflammatory bowel disease in terms of architectural distortion. So in the absence of knowing that history, you can really go down the tubes with diversion colitis thinking that it's IBD. But once you know the history, be very careful, especially if the patient did not have the surgery for inflammatory bowel disease, from saying, yeah, this is IBD, because more than likely this is diversion colitis, which is caused by a lack of short-chain fatty acids, because the colon needs the feces to survive, basically. And if it doesn't have it, it gets inflamed.
So this one, like without IBD history, you would describe and then put differentials to the IBD could be.
Without the history of a Hartmann pouch?
Oh no, without pouch or without, and also without history of IBD, without any history, like you just describe and then put a differential. Yeah,
you have to describe it and put a differential, because it could be a treated IBD. There's not a lot of activity, so it could be like a quiescent, almost normal, with a little bit of distortion in plasma cells in a patient treated with IBD that's well controlled.
So what's the difference? Like the first case you said you can call without history, you can call this treated IBD, right? The first case you showed. So what's the difference between these two? In the
right clinical setting. The first case.
This one. Like if you even first case, if they don't tell you the IBD history, can you also call straight IBD, the first one?
With that morphology, I would say, and in the absence of, say, history of mycophenolate, I would say the findings are most in keeping with. Do I call it straight out on the diagnostic line? No. I'm always descriptive and put in a note. And typically I say almost the findings are consistent or supportive of a diagnosis of inflammatory bowel disease, provided, there are no medications or history of infectious processes are excluded, basically. On this one, there's too little in the way of architectural distortion for me to favor IBD, even if I don't know anything about the patient. Can I say it's not? No. I'm going to give a differential, and the clinician needs to sort it out.
At low power, would you think about lymphoma versus the way it's relating to the glands?
Typically, lymphoma will give you like a big lymphoid aggregate that's destroying the lamina propria, effacing the mucosa. And this one is respecting the lamina, the architecture overall. Yeah.
So how would you call this last case? How would you
This one, I would say colonic mucosa with mild architectural distortion, prominent lymphoid aggregates, and Paneth cell metaplasia. See note. In the absence of any history, the differential diagnosis includes, inflammatory bowel disease, parentheses, quiescent, comma. I mean, because of the lymphoid aggregates, I would think about diversion colitis, knowing that this is from the rectum, even if I don't know that the patient has a Hartmann's pouch. I would say infection is unlikely, and medication probably unlikely.
And for the first case, since the issue came back, sometimes we get the clinicians, they give you just random colon and not have this.
Just on the one biopsy.
Yeah, and then would you say recommend let's say several biopsies left, right, transverse?
Typically we get typically you need more than one biopsy. Yeah.
So you put that in your comment.
Yeah. If I don't get it.
So yeah, for the unusual case, you mentioned that eosinophil is very non-specific, but there's pretty kind of prominent eosinophils in the original case.
Yeah, because it's inflammatory bowel disease tends to have lots of eosinophils. And there's even one paper out there in the clinical literature that suggests that patients with inflammatory bowel disease with lots and lots of severe eosinophilia are likely less responsive to therapy, at least in patients with ulcerative colitis. And some people put that in their notes. We're not in the habit of doing that, but there's data out there for that. Yeah. Yeah. All right. So moving along to number 3, Hamar.
Okay.
Can you read the history,
Yeah,
please?
it's 44 years old HIV male with a bloody bowel movement and polyarthritis. Clinician concerned about IBD.
Okay. So are we gonna stamp him with IBD?
Not yet.
No, because we already saw IBD, right? So what would you say about the architectural distortion?
So some sections there's no distortion, but in some area we can see there's a lot of missing gland and the distortion of the
maybe some bifurcation, right?
Bifurcation also of the gland here.
So some bifurcation, some crypt dropout, lots of granulation tissue, and we have plenty in the way of activity.
Yeah.
So I would say more than I'm used to seeing in this process. So good crypt microabscesses and cryptitis. And then bear in mind that this is from the rectum, so it's way too cellular for a biopsy from the left side. And there's a lot of glandular damage, but the architecture is pretty much maintained. Let's see how the proximal colon looked. What would you say about the proximal colon?
The proximal colon looked well preserved. Architecturally, the gland is there, and there's some space. Space is good also.
Yeah, so I would say it's preserved. There's no inflammation. So it's almost normal colonic biopsy. So a lot of inflammation in the rectum. Proximal colon's normal. Assuming that the rest of the colon look normal like this. With that degree of lack of architectural distortion, inflammatory bowel disease would be low on my list. And with that patient history, it's a male, HIV positive. What are some of the things you should be thinking about?
I think some viral infection maybe, or tiny type of infection.
So not a bad idea, always just look for your CMV. But the other thing that we're seeing a resurgence of is of sexually transmitted infectious proctitis, namely syphilis and chlamydia. And this is a bit of an abnormal case because actually Dr. Montgomery got this case and she showed it to me and said, I think this is probably STI. And I said, well, it's really, really inflamed for STI. And lo and behold, she was right. The patient had positive nucleic acid amplification testing for chlamydia. Plus, he had a history of syphilis in the past. So this is a chlamydia proctitis. And this just goes to show you how typically we say in STI proctitis, inflammation is mild to at most moderate, but you can see anything and everything under the sun when it comes to inflammatory colonic pathology, and just keep an open mind.
Okay.
Yeah. So, and I'll be the first to admit that the history really, really helped in this case. Now.
So what do you do? Immunostain, like for CMV to rule out?
Yes, we did immunostains to rule out CMV, and it was negative. That's never a bad idea.
Because we found that actually there were a lot of the nuclear and with some smudgy nuclear inclusion, right?
Reactive.
Those are all reactive.
they're reactive.
Especially with 1, 2, really has cherry red,
Yeah.
CMV cells in that slide.
It was CMV was negative.
And then
Yeah.
was also one of the reference to.
Mhm. Yeah, and we didn't do adeno, so that's another good one to maybe add. Yeah.
That's my first ever papers from my GI fellowship with highly moderate COD colitis patients.
Mhm.
Whether you needed it compared esophagus, small bowel stomach. And then the colon, the epithelium was so easily infected that immuno never caught a case.
Once in
the
a
esophagus, you needed the immuno. That's
Yeah.
the immuno you were likely to miss if the squamous don't get infected. So the colonic epithelium I've seen so readily. That's the way.
Once in a while, I get surprised, and I brought one of those cases here. I know a patient with IBD. Yeah, but I agree with you. If I don't see the viral changes, if we do the immuno, just sometimes clinicians just call and ask for them. Say, okay,
Yeah,
just do them. This is a patient with a similar history, and this patient turned out well. I won't give it away just yet. So on low power, we have pretty much preserved architecture. Look at this. Even though the lamina propria is expanded by inflammatory cells, the glands are equidistant one from the other. We do have areas where there's gland dropout, like there and maybe there as well. And this is what I'm used to seeing in patients with SGI proctitis, just a little bit in the way of inflammation, maybe some cryptitis here and there, but not to the degree that we saw in the previous case. The inflammation consists of, in the lamina propria, some histiocytes, plasma cells, and some neutrophils and lymphocytes. And some cases have predominantly plasma cells in the lamina propria. Some cells have predominantly eosinophils, histiocytes in the lamina propria. So not cases, I used to think when we started recognizing these that all of the cases look the same, but we've learned in the past couple of years that there's a spectrum of histologic changes that can make it really challenging. The good thing about this case is we do have the immuno at Hopkins, and immuno will be negative in the vast majority of these cases, but once in a while you'll catch one positive case, and this is one of those. I mean, look at them go. So it was loaded with organisms. So why is it important to identify these cases? Well, because we do these patients a great service by calling this an infectious process and getting them the proper antibiotics. Many of these cases, especially when we were starting to recognize them, were both clinicians and some pathologists were, leaning towards IBD. And I had 1 or 2 cases that were treated as IBD for a certain period of time. Specifically, I'm remembering a patient with chlamydia, and he developed a stricture in the rectum, because he wasn't treated properly.
This was chlamydia?
This was syphilis. For chlamydia, there's no immunostain. Actually, I misspoke. There is an immunostain. I think the CDC uses it, but it's not, available for like massive consumption. Yeah.
If you don't have the immunostain, what would you do?
Active colitis with, you mean for special stains? For special stains, if you don't have the immunostains, you can always do the Worthing story and pray. But the chances of maybe like the 20 cases that I've seen, I've stained a few for Worthing story. Yeah. I've had 1 case where I found a single organism in the submucosa. Why in the submucosa, I don't know, but it was there. And it was a clinician who did not want to believe that the patient had syphilis. And I was really hoping, and I went under oil and then found the organism. Yes, because I wanted the patient to get treated. And I said, I really need to find something here. And that's the only case I've seen. The thing is, the Worthing story tends to be really dirty and very difficult to read, especially when you do, especially in the anus. So here's, speaking of anus, here's a biopsy from the anus. And you can see these changes in specimens from these sites. And what you'll see is a massive pseudoepitheliomatous hyperplasia that sometimes can simulate well-differentiated squamous cell carcinoma. And then this really in-your-face dramatic lichenoid, lymphoplasmacytic, sometimes histiocytic, inflammatory response underneath the squamous epithelium that tends to be angiocentric. It loves the vessels. The other thing you might see is endothelial cell swelling. Let me see if I can find a couple of heaped up endothelial cells. Oh, sorry. So that's another feature that can help you. So, but the main finding is at low power is just massive lichenoid response underneath squamous epithelium that's markedly expanded with pseudoepitheliomatous hyperplasia, and many times there's active inflammation, even associated ulcerations. Many times these patients are co-infected with herpes, and we've had cases where we found both the STI and spirochetosis, both STI and herpes. So if you found the one organism, just remember to think about others.
So then is it a good idea to do some viral immuno all the time in HIV positive patients when we have inflammation like this, like at least an adeno or CMV? Or
Yes,
herpes
always,
immuno?
always. I mean, it can't hurt. It can't hurt.
Continue to these questions. Can you tell, for most cases for CNV from adenovirus? I mean, sometimes
They're different. They're different.
Yeah,
Typically,
but
adenovirus tends to be like a smudgy nuclear, and I think it's harder to spot than to spot CMV because people usually are not thinking of adenovirus. I've had one case that I've been able to identify. Hopefully, I haven't missed too many.
And you mentioned chlamydia. This case is from rectum, right?
Yeah.
Have you ever seen other?
Nope. Endoscopically and histologically, proximal biopsies are normal. Yeah. So the clinical also, if you know what the endoscopic procedures show, that's really, really helpful. If you know the patient's male. Have I had cases in females? No. Have I tried to give females STI proctitis? Yes. Have I been running every single case? Yes. Are there cases reported of patients with rectal chlamydia? Yes, but I have not come across them. The only one that we had turned out to be a transgender female. Another, episode where I went down the tubes is I suggested the possibility of STI proctitis in this male patient because it really looked like STI proctitis. A year later, he gets another biopsy and it's full-blown IBD. So early in the course of IBD, STI proctitis and can really, the cases can look a lot like STI proctitis. So yeah. And this is a patient with chlamydia. I'm sorry, the slide is a little bit faded. I don't know why, because it's from 2015. But this just goes to show you how the pattern of inflammation and distortion is really can be different from case to case. So in this one, did not have as much in the way of lamina propria expansion, but it had some architectural distortion here and there, maybe a little bit too cellular for a biopsy from the rectum. And maybe a couple of lymphoid aggregates, but very little in the way of active inflammation and maybe, a little bit of granulation tissue. And speaking of granulation tissue, on rare occasions, you'll get biopsies from patients with chlamydia and even syphilis, and all you get is just granulation tissue. I've had one case where there were 0 glands, but it was this juicy, very inflamed granulation tissue that was rich in both plasma cells and neutrophils. I mean, the question was whether this was CMV. We did immunostains that it was negative. Turned out the patient had a history of both chlamydia and STI and syphilis. All right, it's moving along. This is taking, I'm kind of spending a lot of time on each one because I'm just talking so much. Okay, case number 4. Who wants to read? Emilio.
70-year-old female with colitis involving splenic flexure and descending colon.
Ooh, yes. Okay, so what do you think about this, Emilio?
So it's preserved.
Yeah, architecture's preserved, yes.
But anyway, yeah, there's like, almost looks like there's some fibrin deposition.
Yeah.
And
So
then at the top, there was some vessels here that looked like they were thrombosed as well.
Mm-hmm. So basically, a little bit of pseudomembrane formation.
Right.
The one thing that's most striking about this biopsy is perhaps the lamina propria looks how? Lamina propria looks kind of pink or hyalinized.
Oh, yeah, right.
Yeah. The other feature that we see here is this almost like trophic or withering crypts that cytologically look pretty ugly. And to the untrained eye, a first or second year resident, it might look at these nuclei and might be thinking, oh, wow, is this dysplasia? Is this, and this is what you see in patients with ischemia. So basically injury that's predominantly superficial with relative preservation of the bottom crypts. very hyalinized lamina propria when the ischemia has been ongoing for a while. It may or may not be there when the ischemia has been short-lived. And here you can see very nicely the superficial injury with relatively preserved bottoms. And I find the cytologic atypia really helpful when I'm dealing with cases where I really don't know what's going on. I've caught maybe 1 or 2 cases of patients with, like, subclinical, very mild level ischemia, that the only finding was just this cytologic atypia that I don't know where it's really coming from. And I'll show a case down the road. Actually, I'll show it right now. So this is a patient who, I don't remember the clinical history, but I just thought, I mean, the architecture is preserved, but it's just, it looked very blue, and the glands look a little bit shrunken, and the cells look a little bit, the nuclei look a little bit atypical and dark. And I said to my fellow, it looks like the atypia that typically you see in patients with ischemia, but let's just call it colonic mucosa with reactive changes. I don't know what's going on. And then the next part, this is what we get. So clear, clearly hyalinized pink lamina propria with injury predominantly at the surface, even some pseudomembrane formation and very small atrophic microcrypts that actually are closer to each other than in the normal setting, because there's been collapse of the lamina propria due to the ischemia. And speaking of pseudomembranes, what's the first thing that you think about when you talk about pseudomembranes?
C. diff.
Yeah, exactly. But as we just saw, C. diff is not the only process that will give you pseudomembranes. Ischemic injury can also give it to you. And the one thing to note is that, so this patient had C. difficile colitis by laboratory, but he was not responding to treatment, and they just decided to take a biopsy. And you can see here that in the lamina propria is not hyalinized. Now, does that mean that ischemia is excluded? No, because if it's, it depends on the clinical history. If it's recent ischemia that happened within, 24, 48 hours, the lamina propria may not have had time to hyalinize. How long does it take for the lamina propria to become pink? I don't know, but longer. So C. diff. Ooh, another mimic of ischemia. And you can see why this mimics ischemia. The lamina propria is kind of pink and hyalinized. On top of that, there's actually some architectural distortion. This gland here is trying to grow sideways. So if you tell me this patient has a history of treated IBD, I would say, sure, why not? The other thing that you see is a fair degree of eosinophils. Sure, IBD can have eosinophils, and why not in ischemia? But then what else do you see? There's some atypia in the fibroblasts, right? In the stromal cells around these glands. What else? What else? What is this? Yeah, and how does a vessel look?
Very thick.
Yeah, thick and hyalinized. So when I see that, the first thing I think about is what? Let's say.
Inflammatory fibroid? No.
Yes, treatment effect, radiation. So this patient had a history of, I wrote it here on the slide, history of prostate cancer. And this is a radiation proctitis. So radiation proctitis can have the lamina propria of ischemia, it can have the architectural distortion of IBD, can have the eosinophils of IBD and collagenous colitis. So clinical history is just, it's key. Speaking of radiation, as with everything, the patterns are not set in stone. This patient had a history of radiation also for prostate cancer, but the pattern is a little bit different. Yes, the lamina propria is a little bit hyalinized, and maybe there's some architectural distortion, but it looks less striking than the other one, and you don't have a good, juicy, hyalinized vessel to really tip you off. But you have another finding to tip you off, and that would be this. These dilated vessels that run parallel to the epithelial surface. And you'll see dilated vessels, oh, this is a good one right here. Dilated vessels that tend to run parallel to the epithelial surface. And do they need to run parallel to the epithelial surface? No. You can just have in some areas just dilated vessels, period. But this is just a cool finding that we tend to see in our patients that get treated, for prostate cancer that get treated with, radiation. So that's that. What's case 5? Let's see, who haven't I called on? Oh, I forgot your name, I'm sorry. Mallory. Can you read case number 5?
A 45-year-old female with chronic watery diarrhea.
Yes. Well, kind of the story kind of gives it away. Well, we'll just make it into something. We'll make a discussion out of it. So what do you think about this? I mean, even from this power, so let's talk about architecture first. What do you think about the architecture, Mallory?
So the architecture looks pretty preserved.
Mm-hmm.
You see the gland.
Yeah, there might be a gland dropout here and there, but that's okay. What else?
And then right underneath the dense inflammation within the lamina propria.
Yeah, so expansion of the lamina propria by inflammatory cells. That includes plasma cells, lymphocytes, and some eos. And what else?
And then there's this collagen band, or band, like collagen band underneath the
Mm-hmm.
and within the band there's also inflammatory cells.
Yeah. Exactly. So the band entraps inflammatory cells and capillaries, and it's not just the thickness of the band that really catches your eye, it's the irregularity of it. So you don't have a thin, smooth line anymore. It's just thick and irregular, just throwing like feet down into the lamina propria. There are also a few lymphocytes in the epithelium, but that's not the main finding. The other thing you might find in some of these is some degree of active inflammation. And let me see this one. This is another case. This is a little bit more subtle case of collagenous colitis that had some inflammation, some acute inflammation here and there. Just, I think there's some neutrophils. I don't know if that's an eel or a neutrophil. I can't see very well, but just trust me, they were there. So, and here's the trichrome stain. Do you need a trichrome in order to diagnose it? No, but if I'm on with a first or second year resident and they've never seen a case, I typically order it. And it's just really nice to see the difference in the collagen table from the normal case that I showed and a case with collagenous colitis. And you can see this really irregular collagen band that entraps capillaries and inflammatory cells. What's the other thing that you can see once in a while in these cases? That was the right colon, and this is the left colon of the same patient. Once in a while, you can see Paneth cell metaplasia. So features of chronicity, including mild architectural distortion, can be seen in patients with collagenous colitis, including also some activity that does not preclude the diagnosis. So don't be afraid to call it if you have, otherwise have the good features to call it. This one actually had plenty of Paneth cell metaplasia. Some cases, and here's actually the trichrome stain on that one. So very nicely irregular.
Which cells are making that collagen?
It's a good question.
Epithelial cells laying down extra basement membrane.
I don't know. That's a good question. I don't know. Maybe. Who knows?
Oh, actually, Brian West told me about a Japanese electron microscopy study that showed that there are a form of fibroblasts in the lamina propria of the GI tract from the stomach all the way down to the colon. They're like, they have processes going in all directions, and they meet each other at the tips of the processes. And what these Japanese folks showed by EM is that there actually is no cell membrane where they meet. So it's a giant incision. And they're a type of fibroblastic structural cell.
Wow.
Yeah, and so implied there's also communication through the lamina propria. But maybe those.
That sounds like something that you would be very interested in. Yeah, that sounds like you. That sounds like you.
But maybe they're lamina propria cells.
Yeah.
Yeah.
Yeah,
I don't know.
perhaps. And then some cases actually show features of both lymphocytic colitis and collagenous colitis. And what do? I just describe them. They're treated the same way. And actually, I make it very clear in a note to say that many of these cases are due or as a result of medications. For example, certain proton pump inhibitors such as lansoprazole and omeprazole can be associated with collagenous and lymphocytic colitis. I had a patient once that had both lymphocytic gastritis and colitis on omeprazole. I had just read about it. I told the clinicians, okay, well, let's try it. Switched medication. Patient came back clinically fine, histologically fine. So sometimes I say that so that they will not add something as opposed to take something out or switch something, so that the patient gets better without the need for another medication.
If it get really severe, can it catch up by endoscopy or always might?
Typically, there are no endoscopic findings. However, some cases of collagenous colitis, especially some that are associated with proton pump inhibitors, can show these very dramatic, linear, deep ulcers that once in a while can perforate during the endoscopy. Yeah. 5, 6. So speaking of microscopic colitis, this next case is actually a case of lymphocytic colitis. And it's similar. Instead of having a thick lamina propria, you have a somewhat preserved, thin, straight, smooth lamina propria, but you have tons of intraepithelial lymphocytes in the surface epithelium. Do we count them? No. We just know what is normal and what too much is too much. Besides having that, the low power appearance, of course, will have a lack of significant architectural distortion. And you will see it will look a little bit blue. Oh, where's my arrow? It will look somewhat blue at low power because there's loss of surface epithelial injury, loss of superficial mucin, and the lamina propria will be expanded. So that's one case. And here's another, a little bit more of a dramatic appearance with really, really good syncytial-like looking surface epithelium with tons of intraepithelial lymphocytes and mucin loss. What would be in the differential? So you would think about, so again, drugs. With this look, I would also be thinking about, lymphocytic colitis is associated with celiac disease in a subset of cases, I think up to like 25%. But also autoimmune enterocolopathy can have this degree of intraepithelial lymphocytosis. In addition, you tend to see more in the way of neutrophils and apoptotic bodies. And the patient will present with a history of just dramatic, profuse, watery diarrhea.
What do you mean by syncytial surface epithelium?
So the epithelium looks like a syncytium. Sorry, I don't know that I'm pronouncing that correctly. And you can't really see the difference between one cell and the next. Yeah.
Oh.
That's like flat, and it's like all is like one single like mass of cells. Yeah. Okay. And in a subset of these cases, sometimes they biopsy the terminal ileum when they're in there, and you can see even increased intraepithelial lymphocytes in biopsies from the small bowel. This patient had lymphocytic colitis and also increased intraepithelial lymphocytes in a biopsy from the terminal ileum. And again, some cases have features of both, and I just describe them. Oh, case 7. The next case is, who's next? We go to Summer again?
I can read it.
It doesn't matter.
Ask you,
Sure.
for the lymphocytic colitis, if like the surface didn't show increase of lymphocytes, but it could show that, do you also count? Oh, you said it's early, could be early.
So some cases are iffy like that. I haven't really encountered ones that showed just intraepithelial lymphocytes down in the crypt. There's always, in my experience, some degree of surface epithelial lymphocytosis. Now, I'll give you one thing. Sometimes you have mild increase in intraepithelial lymphocytes without lamina propria expansion, without loss of mucin, without surface epithelial injury. I don't know what to do with those cases. I give a differential diagnosis: early lymphocytic colitis, NSAID injury, resolving infection. And I've asked other colleagues, and everybody does the same, sort of thing, because we don't know what to do. Typically, those patients don't have a history of chronic diarrhea. Typically, they're like on screening colonoscopies or histories that don't really go along with a microscopic colitis kind of picture. All right,
Okay.
case 7.
7 is 42-year-old male with diarrhea, started post kidney transplant.
All right, so what would you say about the architectural distortion? It's really dramatic, right? And not only that, what else do we have?
We have, you mean this area?
Yeah, these cells, this glands right here. What does it reflect?
Pylori gland metaplasia.
Yeah, exactly. So pylori gland metaplasia. So pylori gland metaplasia should be Crohn's. No, you can see pylori gland metaplasia in ulcerative colitis, in NSAID-associated injury, and also in mycophenolate-associated injury, as this case is. And the tip of it, this patient is a solid organ transplant recipient. And one useful clue that Starr and Otts described a couple of years ago is the presence of eosinophils, especially if you're thinking about GVHD versus mycophenolate-associated injury. Patients with mycophenolate-associated injury have many more in the way of eosinophils, a lot more in the way of eosinophils than GVHD patients do. So that's really, really helpful.
Is there a number, some 15?
I think it's more than 15 per high power field. Typically, I just say, the presence of eosinophils or prominent eosinophils, favors mycophenolate. The other thing is you don't see any neuroendocrine cell aggregates. Those you see in GVHD. The other thing is you don't see apoptotic microabscesses. Those will be in GVHD, and you will not see them in mycophenolate. And then, actually the main finding, let's talk about the main finding, which is what? Yeah, exactly. And let's see if we can find some right there. Yeah, apoptotic bodies. Yeah. So I find that at low magnification, this is one of the entities that most resembles inflammatory bowel disease. And this is, for comparison, a case of GVHD. I tried to find it. Here you have good in the way of apoptotic microabscesses. And what else do you not see?
Eosinophils.
Yeah, exactly. Very little in the way of eosinophils. And I dotted an area of endocrine cell microaggregates. This is a more severe case of GVHD, and let me see if I can find that area right there. So neuroendocrine cells are a little bit more resistant to injury. So in the setting of GVHD, yeah, if you see those, it's more likely the patient has GVHD. Even though mycophenolate tends to be given to patients with solid organ transplants, some patients with bone marrow transplants also get mycophenolate, so it makes it really fun when you're trying to decide one way from the next. But those features that were reported are really, really helpful. And I said I was going to talk about CMV a little bit. Every time you see apoptotic activity, you have to think about CMV, and we always just throw an immuno. This was a case of an IBD patient where it just didn't make sense for a patient with IBD to have this many just neutrophil apoptotic microabscesses. And I thought, well, maybe this is CMV, but I don't see the viral cytopathic changes. But lo and behold, the stain, the stain was positive. And then I went back and said, oh, yeah, there they are, there. And there's a more better one. Hold on. Oh, right there. And that's the one that actually lit up on the stain. Yeah. But really, what tipped me off was the apoptosis. I didn't pick up on the viral cytopathic changes. So
sometimes the location also right to look for the inclusion. I mean, when we talked about adenovirus versus CMV.
Typically, adenovirus will be on the surface, and the inclusions will be like smudgy, dark chromatin in those epithelial cells. Yeah. All right. And then another drug-associated injury. Few minutes left.
You can try that.
Yes, refat. I forgot to ask you.
So we have history of 60-year-old male with diarrhea and history of melanoma.
Okay, so what's the tip off?
So that means that it's not melanoma. So probably we are looking at some drug-related injury.
Exactly.
So this is used for melanoma treatment.
Exactly, and that drug would be?
ipilimumab.
Yeah, exactly. So features associated with ipilimumab injury are increased intraepithelial lymphocytes, and guess what? Apoptotic bodies. Let me see if I can find. There were a few here. There weren't two. Maybe one right there. And with ipilimumab, I find that there's also a range of histologic appearances. Some cases look more like autoimmune type of colitis, and some cases look more like infectious colitis. The other thing you'll see is like this really dramatically expanded lamina propria with lymphocytes, plasma cells, and lymphocytes and plasma cells. And then there's some degree of surface epithelial injury also with increased intraepithelial lymphocytes. Some cases, so they treat these patients with steroids, but some patients don't respond to steroid, and a subset of them may perforate actually at multiple sites, and this is one of those cases. Basically, you'll see just extensive dramatic ulceration and pseudopolyp formation associated with these dramatically dilated glands with intraluminal apoptotic microabscesses. So just keep that in mind. So two nucleates on the block are idelalisib, which is a drug used to treat B-cell malignancies. And guess what the characteristic finding is? An apoptotic colopathy with some neutrophils and some intraepithelial lymphocytes as well. So this looks to me a lot like what I just showed with ipilimumab-associated injury. So it depends on the clinical history. If the patient has a history of B-cell lymphoma, then it's probably idelalisib. If I don't have a clinical history, but I see prominent apoptotic bodies, I always mention the possibility of a drug. And of course, do a stain for CMV. And then the other new kid on the block is PD-L1 used to treat certain malignancies such as lung cancer. And guess what the main finding in patients with colitis associated with ipilimumab is? Apoptotic colopathy. We've seen less than a handful of cases, but they all showed more or less the same findings. So prominent apoptosis, drug. Last but not least is case number 9, which is an 8-year-old male with thickening of the ascending colon. This case came down, rule out IBD, of course, and this is what we found. So at low magnification, you see the architecture is completely preserved, but the lamina propria is being expanded by something. So what are these, Hamar? Yeah, exactly. So this is Crohn's. No. Why is it not Crohn's? So two main reasons why it's not Crohn's. So number one, the architecture is completely preserved. Okay, that can happen in Crohn's. Why not? The granulomas are too good to be true. Right. You can have granulomas sometimes will form in Crohn's, of course, rarely, but they won't be coalescing. They won't be expanding the lamina propria to this degree. So if you have coalescing masses of granulomas, very romantic. I like this place. So if you have big coalescing masses of granuloma expanding your lamina propria, think something other than Crohn's. Think of infectious process, especially if they're necrotizing, but even if they're not. And also think of sarcoid. This patient had sarcoid. So I said, this is probably not IBD. Clinicians came down, oh, we want to look at the biopsy, of course. Turns out that they went back and talked to the patient. The patient has a history of uveitis with characteristic features that were good for sarcoidosis. And nobody knew about. They treated the patient for sarcoid, rebiopsied the patient, and he was fine. There were no more granulomas on multiple repeat biopsies. And now compare those grannies with the grannies in Crohn's. So here's a giant cell right there, but there was a better one right there. So they're like kind of blending in with the background, and they're kind of difficult to spot. That one's a little bit better, form, but they're very, very sneaky. So that's what you want to see in patients with Crohn's. Now, having said that, some patients with Crohn's, just like this one, have well-formed granulomas like this. So once in a while, you'll get this, especially if it's a kid, especially if it's a well-treated, a patient that's responding well to treatment. Last but not least, of course, you have to think about medications. So this is a patient who had a history of protein-losing enteropathy, not symptomatic. Do a couple of biopsies, and this is all we found in the colon. Really well formed, and it looks like a sarcoid granuloma, compact, and nothing in the way of architectural distortion, maybe a little bit of activity here and there. And the clinician's like, well, you say there's granulomas, why is it not Crohn's? I said, well, because there's no architectural distortion in the background. But I was on with one of our star residents. She was a first year, and she actually looked this up and see what else could give you this. It turns out that a subset, very minority of patients that are on tumor necrosis factor for rheumatologic diseases. This patient specifically was on Enbrel. I forget what the generic name of it is. Etanercept. And a small subset of these patients can develop sarcoid-like granulomas that respond to either switch to another TNF-alpha inhibitor or to removal of the drug. So far, only reported skin, lymph nodes, lung, and maybe one other site, but never in the GI tract. And now we have like a small USCAP poster describing the findings in patients on tumor necrosis factor alpha inhibitors. So something else to think about. Patient was taken off the drug, rebiopsied 1 year later. Colon had no granulomas, but there was one remaining granuloma in the stomach, but it wasn't well formed. It wasn't compact. It was very ill-defined. In fact, it was missed during sign-out. And when we pulled the slides, we just found a very ill-defined, poorly formed granny. And which is not surprising because when you read the literature, radiologic findings typically take between 6 and 12 months to resolve in patients who develop sarcoid granulomas, at least in the lung. So maybe the process just takes a little while to resolve after the patient's taken off the drug.
Since the patients under testing are due to rule out mycobacteria.
Yeah, so the patient, we did, all the stains and all the stains, but they're, albeit they're low yield. The patient had no risk factors for TB. They never tested him for TB though, but they thought clinically that's not, an issue. He got tested for a couple of other things. His ACE was within normal limits, and nothing. Just removed the drug and said, okay, let's see if this works, and that turned out to be. The patient had, he was taking TNF for ankylosing spondylitis. Ankylosing spondylitis, yeah.
Coming back to our case that we had today, 8-year-old. So can we think of with this type of granulomas, chronic granulomatous disease or something?
So patients with chronic granulomatous disease, about less than half develop granulomas. I don't know that they tend to be as well formed as these. I would have to check the paper by Mietinen and at the NIH a couple of years ago. But the main finding in those patients is pigmented macrophages. You would think it's granulomas, in chronic granulomatous disease, but no, it's pigmented macrophages in any of the layers of the bowel. In biopsies, you'll see it on the biopsies, but autopsy cases that they found these pigmented macrophages anywhere. But definitely, it's in your differential, especially if the patient has a history of chronic infection since childhood, blah blah blah.
What would be the diagnosis for this case? Still, it is IBC.
I would say I would be descriptive. I said, colonic mucosa with focal active inflammation and focal, well-formed, non-necrotizing granuloma, C node, lack of architectural distortion makes IBD unlikely, consider sarcoid, consider infection. And now that I know about Enbrel, consider medication. Yeah, that's it. That's all I have.
Thank you so much.
Thank you. Wow, made it in 1 hour. 1 hour. That's what I want, 1 hour. All right. I think the box that I have is not going to be enough for me to take all the slides. Can I have another one, please? Thank you. All right, that was a lot.
Yeah, that was nice cases. Thank you so much.